we've looked at our claims, and we have the least ability, it seems, to control the types of providers people use, where they go to get care, and whether or not they're actually getting the quality care that they need, that's the appropriate care, or the right care at the right time from the right person. And so they look to the HMOs, and what this clip says is, you know, very scary, Jennifer. Does anyone else have an HMO horror story? Which really was the setting when kind of the next phase of the insurance for mental health came around. And that was managed behavioral health. And we're still in the phase of managed behavioral health, and it still is going to have an enormous impact on how parity actually gets played out. So the way this gets sold, essentially, to the marketplace is, we have an idea for you. We're going to manage your behavioral health, and we're going to do it in a very special way. And have we got a bargain for you? And so what came into being were carve-outs, mental health carve-outs, behavioral health carve-outs. And actually some work I did about 20 years ago looking at carve-outs in the California area, it turned out to be much more typical than I thought it would be when I look back at it now, because the kinds of carve-outs that we have today for behavioral health are very, very, very similar to the kind that there were 20 years ago. So the way carve-outs work, as you may know, is there's a separate vendor, and this vendor arranges the network of mental health professionals. And if you have insurance through your employer, the employer would cover most of your medical expenses through a regular insurer or a health plan, but there would be a separate vendor who would handle your behavioral health needs. So if you had a mental health issue or problem, you would call an 800 number, you would get referred to someone in the network, you would go see that person, and then there were usually limits on how many visits you could make to this carve-out vendor before either the provider had to file some papers saying that this was medically necessary, or it was just capped at 5 visits. So originally those were capped at 5 visits, and then expanded to 10 visits, and that 10-visit cap hung around for about 10 years. It's been relaxed somewhat now, but this carve-out was really such a kind of a crash to the community. It's all of a sudden, everywhere, there were these behavioral health carve-outs. And it really took about 2 years before the for-profit firms came in and made these deals with insurers. And it turned out that the research that was done on it said, you know what, it seems to be working in some ways. And in fact, Massachusetts implemented it very early on for its severely mentally ill. It had a carve-out for mental and substance abuse services. And so some of the original findings from what are the effects of these kinds of carve-outs came out of Massachusetts, and they were for the severely mentally ill. And what they found was very similar to what we found in the private sector, which was that more people got into treatment, more people got into outpatient care. But where the cost savings were was on the inpatient side. People were just kept out of the hospitals, or lengths of stay were reduced, and that's where the cost savings were. And so some would refer to that as low-hanging fruit. And so it looked initially like this was a technique, this was a vendor arrangement that could really save money, because it would get more people into treatment, but it would keep the expensive treatment kind of out of the coffers. On the private sector, like I said, it's pretty much the same thing. It does seem to lower cost, but it lowered cost on the basis of keeping people out of the hospital, which may be appropriate. So less inpatient, and the providers were very happy with it. The carve-out vendors who were in the networks expressed a lot of satisfaction from doing that. So as more research was done on the carve-outs, and we realized that providers are happy, and it does seem to be saving money, and more people seem to be getting into care. If you looked more closely at the research, what you found was that it did reduce some of the administrative barriers. But if somebody had a serious mental illness, or somebody even had severe depression, which isn't often considered one of the kind of the schizophrenia, the really, really difficult chronic, severely mentally ill, those people were cut off from services. 10 visits is not enough. And so within the carve-out frame, the seriously mentally ill, or those who needed more services than 10 visits, were really getting shunted off to the out-of-pocket world. And so if they wanted to continue treatment with the same provider, if they wanted to continue treatment with another provider, if they wanted to continue treatment with a provider who was not in a network when the carve-out came in, it was all out-of-pocket. And so there's not a lot of parity in that if you think about whether you're going for your diabetes care or whether you're going for your depression care. There also were several studies that looked at what's the effect of behavioral health carve-outs on children. Because children are different. They're not just little adults. They have different types of needs. And it turns out that children are really getting even less care than the adults were who were getting care. And so depending on kind of which research you read, the prevalence of mental disorders, not even drug abuse and alcohol among children is anywhere from 10 to 30%. And so those are really high numbers and worrisome if you can't get those individuals, those kids into treatment. And so only about 60% of those who are diagnosed with some kind of mental illness actually get treatment. And that's a function of insurance in many cases. The S-chip is helping that somewhat. But lack of primary care providers to do the screening, the pediatricians to actually recognize this. There was an article you probably saw on the front page of the New York Times yesterday about the difficulty in finding enough primary care providers. And that's not just for mental health, that's just in general. And the president has certainly been trying to come up with, and his staff's been trying to come up with ways to increase the number of primary care practitioners. And it's very critical when we're dealing with children, because children do end up with family practitioners and with pediatricians. And so if you pull them out into an adult network of providers, odds are they won't be able to get the kind of specialty care that they need. So carve-outs weren't perfect for a lot of reasons, and certainly not for children. So what happens when you have these different insurance, these different ways of paying for care, and you have these different ways of kind of translating the research for kids or for adults? You end up with segmented policies. You end up with policies that take care of one piece and not another. And I'm sure Senator George knows better than any of us, than I do, that these kinds of segmented health policies help in some cases, in some pieces, but trying to integrate them and trying to make them effective for a broader population is extremely challenging. So, of course, what's come in as a result of this, just in the last 3 to 4 years, it's the notion of integration. It's the notion of integrating medical with mental, with substance abuse, with housing, with social services, with criminal justice. And so there are efforts around the country to try and bring all of those entities together in a completely integrated model. I've been doing some research on that over the last couple of years, and there are places in the country that have perfected this ability to integrate all of these services so that any door an individual walks in gets them to the other linkages that they need, whether it's for social services or housing or for substance abuse treatment or vocational training. And so this whole notion of integration is the charge at this point in trying to try and get people the health care they need and to improve their kind of quality of life. Now, some people are skeptical about integration, and this clip says, "Our integrated approach to medicine skillfully combines an array of holistic alternative treatments with a sophisticated computer billing service." And that was for, and even today could be your idea of integration, could be mine. We hope not, but. So what's the result of all this? Well, what happens? Superman flies in, and we enter the carve-in. So now insurers, employers, public entities are saying, maybe this carve-out isn't such a great idea. It did keep costs down, but maybe we need to bring it back in to the medical model. Maybe we need to look at taking care of mental disorders and substance abuse disorders back in the medical model. So what if we carved that back in? And so now there's these partnerships, this integration I was describing before, and there's partnerships between universities and health systems and states and communities and public health departments and provider groups to try and bring all of these pieces back together again